Happy Wednesday, Dr. Richards. It's a little change of pace today.
I know. I kind of like the midweek. I don't know
Yeah,
if this is normal for you to have this time, but I'm glad we're getting it in now. It's a nice I don't know, little pick me up middle of the week. It's like a
yeah,
caffeine shot.
I agree. We'll see how our brains are working midweek as opposed to the end of the week.
Yeah.
Uh, so today we're going to touch on low back pain, which I think is, somebody in your life that has had low back pain if you yourself has it. It's probably one of the most common things that we certainly see as physical therapists, but I don't know what the current statistics are, but I know it's very prevalent in the world of orthopedics and healthcare in general. It costs a healthcare system quite a bit of money, and it's I think one of the issues with it is it's hard to define, and sometimes that's good to be like real general with how you talk about things, but it's a difficult thing to define, so therefore sometimes it's a difficult thing to treat, and hopefully we're able to shine some light on our experience and how we think about low back pain because we certainly see it plenty.
Yeah. Yeah. I mean, I think statistic wise, actually, low back pain is the leading worldwide cause of disability.
Wow.
I just pulled up some numbers too. It looks like in 2020, 619 million people suffered from low back pain globally. And I'm pretty sure there's this statistic that like 80 to 90% of people are going to have low back pain at some point in their life. So
Yeah.
really affects nearly all of us, or actually all of us, whether it's directly or through someone else. So I think this is a good topic for us to touch on today.
Yeah, we've done a couple other podcasts on pain in general. So this is just, to reiterate some of the things we talked about there is when we're looking at pain, and low back pain is probably one of the most common types of pains that you'll see from a musculoskeletal standpoint. But the same rules apply from our previous conversations where we're not necessarily looking at pain and structural damage or structural injury as the same thing. And certainly as physical therapists, the information that we might get from an x-ray or MRI about what's going on with someone's back, it may not be very relevant at all to what we do. And sometimes it can be interference to what we do, right? Where it can get in the way of us having actually a more thorough and direct assessment process, or it can get in the way of the patient allowing us to have a more direct assessment process
Yep.
because they already have conclusions that are drawn based on some idea about structural pathology. When I'm using that terminology, you can think of things like osteoarthritis, herniated discs, sciatica. These are common terms that tend to tie into structural anatomy, but they're not always important for what we do, or at least we have maybe a different way of categorizing things that might look similar to that.
Mm-hmm. Yeah, I think too it's there's Larimer Mosley is a leading neuroscientist out of Australia. He's also a physical therapist, and he actually did some research looking at the effects of, like, I think most people, if you get imaging on your back, your doctor probably tells you not to look at the report of imaging, and then you look at it anyway,
Mm-hmm.
and you see like some words like disc bulge, herniated disc, protrusion, joint space narrowing. And actually, Larimer Mosley's work seems to support the fact that reading that actually makes your pain worse than
Yeah.
if you had the exact same pathology and didn't read it. So just
Yeah.
some more concrete evidence that you're kind of hinting at about where imaging, it can matter, but it doesn't a lot of times change or actually affect what we're doing as physical therapists, and in ways can hinder us pretty directly in terms of that.
But with that being said, what the hell are we doing as physical therapists? Like, so what if it's not, making change to that? Because I think that surprises a lot of people, a lot of patients. They come in and tend to have an idea that, if they give us a diagnosis or if we have information about their back from an X-ray MRI, that's going to we'll have some type of protocol to treat that. Right. And I probably get that more than anything is just like, oh, I got sciatic. What do I do about it? Like, I can't help you there. Like, I need to assess the different things, and ultimately it's a matter of asking questions and getting responses to our questions. So what are some of the questions that we need to know? one, we have to know like what makes the pain present, what makes it better, what makes it worse. The with what, as I like to think about it, is way more important for me as a therapist than the image or even the where. It's like, so the with what tells me, like, in any moment, all right, are you getting pain right now, like sitting here? Are you getting pain at, like, when you bend forward? I need to know the with what, because that's what we can actually deconstruct and change, right? And ultimately, that as movement professionals, we're affecting people's movement. We're able to manipulate people's movement, educate people on movement. But that is the with what, right? That's the movement. So we that's, to me, like the biggest question is like, what makes your pain better? What makes your pain worse? That with what.
Mhm. Yeah, I always think of imaging as really like a snapshot in time. Like it just gives us an idea of what is going on kind of under the hood at the exact time that it was taken. And
Mm-hmm.
understand that even that snapshot imaging doesn't necessarily correlate to what you're actually experiencing in terms of symptoms and in your day to day. But yeah, I think we're looking at movement, and what's exciting about movement and taking that approach to an intervention is that it's something we can. They're immediate action items we find from watching someone move. We can immediately figure out, okay, what modifications do we need to change? What can we actually work on to start to make a change? Whereas imaging doesn't really give us any ability or indication about how to take action about things. And like you mentioned, I think the with what is such a vital piece of this. I also think it's important just thinking about big picture chronicity of the
Mm-hmm.
the thing they're experiencing. People who have a more acute episode of pain where they quote throw their back out, like just picking something up 2 days ago, is going to be probably treated a little bit differently than someone who's had low back pain for 10 plus years.
100%. And I think with related to that is the idea that the intensity of the symptom does not give you any information or any reliable information about how bad the problem is, right?
Mm-hmm.
So the initial pain, especially acute pain, of the idea of throwing one's back out, like usually that pain is the most intense it's going to be, or it could be. Some people will report that it's worse than childbirth. I've had my female patients tell me that, especially if there's any type of irritation to, like a nerve down the leg. Some of that pain can be so intense, but it doesn't mean it's going to stay that way. And a lot of times, the recovery process for that is much quicker, and it's almost a natural process. But it's shocking how painful it can be to people early on. So that there's this danger signal that's really, really high red alert that's saying something's got to be really wrong, and oftentimes it's not. It's just a response to something that happened that the body found threatening in the moment, and then it goes through sort of a natural healing process, if we can call it that, which at least follows like more of a natural timetable of how inflammation will work in the body and move through the body. But oftentimes there does not a real need for a lot of intervention other than time and maybe some medicine to make the intensity of the symptom come down early on, right? But we tend to not see those presentations as much because they resolve on their own a lot of times, unless
Yeah.
we're working with somebody in a training facility and all of a sudden they get hurt, maybe in a session. Then we have to understand how to educate somebody in that moment. But typically, like physical therapists will see people when things have gotten more chronic or after surgery or something along those lines. But yeah, the intensity of the symptom oftentimes is not what people start to really have life changes, like where their function really gets brought down, or where they really just feel like they're being isolated by their pain because it's such an acute small window of time that they're in pain for. So it's typically the sort of like the opposite thought process there, where it's like it's the intensity that's the problem, but usually it's the chronicity that becomes
Yeah.
more of the problem in our healthcare system.
Yeah, and interestingly, I think a lot of times it's like the actual worse the pain, sometimes the less real damage there is
Mm-hmm.
pathology wise. And the inverse is true too, where
Yeah,
sometimes like the worst injuries actually don't hurt nearly
yeah,
as bad. And yeah, I think being able to kind of move through those acute episodes a lot of times people do it independently without really seeking us out. But when they do, I think in a training setting, a lot of it comes down to, like you mentioned, using the things, different medicines or whatever it is to actually help them just stay on the move and get through that time, and understand that the majority of low back pain cases do get better. Because I think there's a fear when it happens oftentimes of understanding some people have back pain for 10 years and wondering if that's going to be that person who's experiencing it at that time.
Yeah, and I think going back to the statistics you brought up about how prevalent low back pain is, I think it's almost a little bit misleading, because as we talked about in other podcasts about pain, it's like pain is not necessarily a diagnosis in itself, right? Like it's not a pathology. It's more of a sensation in the body that is telling us something, right? So to get low back pain in your life, and I'm surprised that's not 100%, right? It's just, like if you think about it from that perspective, and it would almost be make more sense and be more normal if it was 100%, because at some point in your life, like you're going to have a certain stress in your body that's going to manifest itself in your lower back that says, all right, you got to change something, right? So I think it's important that we try to separate out the idea of low back pain or any, musculoskeletal pain from other diagnoses that we would think about, like cancer or heart disease or things like that, right? Because it's really not the same thing at all. And that's why I think it's so prevalent. It doesn't mean it's the chronicity of any pain could really be the thing that is more life-changing, but just to have low back pain. And that's why I also see that it tends to resolve itself, as frequently as it comes on, because it's not an unnatural process. And then I think where we can help people, and what our education I think is really mostly based on, is understanding biomechanics and biomechanical relationships. So although we aren't going to necessarily associate the structural imaging to someone's pain, we can understand how certain presentations throughout the whole body will change pressure in the body. So if somebody is coming in with pain in their back, and we ask with what makes it worse, and they say sitting. Well, we can look at sitting as, what is sitting, right? It's a compressive load that is through the lumbar spine, through the lower back, but it's, there's a lot of other forces that are going on in the body. So our education is understanding those forces and how changes that we make in the body through movement or through repositioning have direct effects on changes of pressure in the lower back or areas around it, right? And this would be the same conversation for any area in the body. How we would know how to change pressure that would be coming on in the knee and the shoulder, but the lower back it's like the center of everything. So I think that's why it's so common, and it comes on a lot with static positioning, standing too long, sitting too long, because of this central location of it through the body. So our job is really to understand how to make changes in the body that can change pressures. But we also ultimately have to see, does that help? Right. So there is no protocol to say, okay, like if you do this, your back pain is going to go away because it's going to change the pressure in your back because we're making your hip move better. That makes sense theoretically, but there's so many other variables to pain that it may not work, right? It may make somebody worse. It may be hard for them to do what you're asking them to do, which is probably one of the most common things that you see. And all of those things could mean that what you thought was going to work from a biomechanical standpoint didn't change someone's pain. But if we have that awareness going in, we have that starting point, then we have a lot of things to try. And then a lot of times we'll find success somewhere in that process.
Yeah. And I mean, like you said, that's only one small variable potentially out of pain. Like it goes far beyond movement too. And that's why we now subscribe to the biopsychosocial model of pain, looking at, context within the community, social environment, and other things along that line that seemingly, to the average person might appear to not be related, but oftentimes may exacerbate or improve things. If you have outside life stressors going on, pain may be worse, or, the reverse is true too. So I think that plays a really big role into this as well, even beyond what we're seeing biomechanically. But yeah, I think we're always looking at how we can kind of change things or sensations potentially within the body, or look at specific movements and see, what slight change leads to a result. And I think that's honestly the starting place of probably most of what we do.
Right.
Now, kind of building off that, I mean, what are some of the specific things you're tending to look at when you're seeing someone with low back pain, in terms of movement and else otherwise?
So, a couple of things that I want to differentiate off the bat is something like I like to think of, and it's from McKenzie's method of terminology, where they talk about directional preference. I want to see what direction of movement makes things better, what makes things worse. So, does it feel better to flex forward, or does it feel better to extend back? And that can go hand in hand sometimes with these ideas of centralization and peripheralization. So, centralization would be, is the pain more towards the center of the low back, or is it starting to peripheralize out to the side and down the leg? Right. So there is some evidence, and I think it's pretty solid evidence, that if symptoms are moving more away from center, that's not a good thing. Right. So we're doing well for our patients to move their symptoms back to the center. So if we can find a direction that helps to centralize symptoms, that tends to be a good thing. Right. And that's if anyone's ever heard of the McKenzie method, that's sort of like, in a nutshell, what is being done there. And they tend to do that with repeated motion testing. So if you're having somebody move and they move once, you don't get as much information if you have them do in 1 rep as you will in 10 reps, because you can see, with more reps, does it actually get better or does it get worse, right? So you can get a lot of information with repeated motion testing. So I want to be able to differentiate directional preference. And I like to think of it as more of a low-hanging fruit thing than a real, like, I got to be real specific with it, at least at first. And maybe I'll eventually, if I need to, I'll dwindle it down and be more specific. But I want to be able to do it quickly and eyeball, okay, like, you're obviously, and oftentimes you can get this just by talking to someone. Like, what direction do you like to move? What makes you feel better? What makes you feel worse? So, they'll tell you that, and then you can confirm with a movement assessment, and you can get that directional preference. But you can also see if there's any type of centralization, peripheralization going on. A lot of times presentations don't tend to have that, but if they do, that gives you a lot of information. And I think of that as something that I want to make sure that I'm looking at first, because that can make a big difference in what you want to do with somebody.
Mm-hmm. Absolutely. Yeah. I honestly use that a lot. And I think it applies not just to low back, but elsewhere as well.
Absolutely.
So across the whole body. So you're looking at that. And then from there, where else are you looking?
And then I just want to get a sense of, with the directional preference, does it tend to feel like it is more compressive in nature, that like compressive loads, maybe sitting for a long period of time, standing for long periods of time, more towards extension would be more compressive at the lumbar spine or in the spinal segments typically? Or is it more problematic when you're actually opening the joint a little bit? So more, expansive in its provocation. So trying to separate that out, which ties into the centralization or the directional preference. And then the other thing is, I'll look at, is there a side difference, like a lateralization issues? Is somebody tending to bias a lot of movement to one side versus the other? That's definitely something we've both gone through the Postural Restoration Institute type coursework. That's something that came on for me like midway through my career, where I started to get introduced to that. And that's definitely made a big change in how I think about things, where that there's going to tend to be a bias, if we're right-handed or left-handed. There's a lot of different reasons that we might bias our whole being to one side more than the other. And just knowing that bias and then trying to balance it out a little bit, or just cue somebody towards the side that they're not biasing, and then seeing how does that affect the symptoms. A lot of times I get success doing that. So I'll try to look at, the symmetry in hips, symmetry actually in shoulders and other movements that would just give me a sense of like, okay, somebody's like biasing their stance to the right on a regular basis. So what would be some of the cues to get them to put a little bit more load on the left? And what are the relationships at the hips, at the pelvis, at the lower back that are involved in making these adjustments. So that's right after I'm getting a directional preference, and then I'm tying into maybe a one side versus the other, or a lateralization preference.
I like to look at a lot. I mean, I think it's simple, but like just the quality of the movement too, in terms of looking at someone bending forward and touching their toes and seeing, can they actually flex at the low back, or is it kind of locked into extension, and then going vice versa. In extension, see how they rotate and they can laterally flex as well. Because I think limitations in those often kind of help self-select what might be useful interventions wise. Sometimes, especially if like symptoms are more chronic in nature, I think that almost becomes where I start, as opposed to seeing if something feels better or worse, because if symptoms are a little more chronic, they may be a little bit more variable with activity, and maybe not necessarily as consistently, like if I stand too long, this hurts, or sit too long, this hurts. So kind of going after some of those slightly more quantitative changes in terms of range of motion and quality in terms of how it actually looks, I think can become a useful starting place, as long as we're able to connect the dots about why those things are actually meaningful.
Absolutely. And I think, like a broad fundamental there would be, figuring out where people can't move and where people move really well. Right. And, a lot of times what'll end up happening is you'll see people, even people that feel just stiff everywhere, they have somewhere that they can move, and then they move too much from that area, or they have a lot of places where they can't move, and there's just a lot of pressure building up in those areas because they haven't been able to change the pressure and the compression in those areas, because they're not getting any motion to it. So giving people more options for movement is a way that, you often hear it talked about. But if you just see it throughout the body, where does somebody not move well, right? And that's going to look like range of motion testing. And then again, the more understanding we have about those biomechanical relationships, we can start to tie in, okay, a lack of motion in this direction in the hip is going to could very well have a secondary effect up the chain into the back in a consistent way. But ultimately, like, we could make it simpler and just say, like, okay, we see the low hanging fruit of where you don't move well. Let's get you moving better from there. Right. And that could be segmentally in the spine. I think one of the tricky things about spinal pain and then spinal therapy, spinal mobility, is the joints. We talk about the spine as like this one unit, but when we're talking about the lumbar spine, it's really 5 joints. We're talking about the thoracic spine is 12, and cervical it's 7, right? So you have all of these different smaller joints that we want them all to move well. It's really hard to visualize that. It's hard to see it. It's hard to feel it, right? So you get better at that over time, at being able to see where people aren't moving segmentally, but it's really hard to be specific. Where with a shoulder and a hip, it's a little easier to notice and have even your patient notice like a loss of motion, where it's really difficult for a lot of people to even sense that they've lost motion in the spine, because they compensate so well from all of the other segments that are available to them.
I think from motion, one of the next biggest things I tend to look at is just capacity of various areas of the body.
Yes.
Or more broadly, like someone's ability to create and maintain tension. But I think with a low back, like anterior core becomes a big one, as just a starting place. And then also looking at hips, like, can you hold a plank? Can you hold a side plank variation? And kind of teasing out where some of those limitations might be. And I think that oftentimes yields a lot of information, sometimes almost more than range of motion, because it helps us understand, where they actually may be fatiguing in their day to day, and where those areas for opportunity really are.
Absolutely. And I think this is where pain, in any area, fits into this movement continuum idea of really, like, rehab and training. They don't have to be that different. It's just, are we using a symptom as the thing that we're assessing, or are we just using somebody's functional capacity or strength capacity as like their limiting factor? Sometimes the symptom comes on first, so even and then that's the thing that we have to stop whatever we're doing and make it easier for someone. Or sometimes it's just like, nothing hurt, I'm done, my muscles gave out and things like that. But there's a relationship there that I think is closer than people realize, where if somebody doesn't have pain doing a thing and the pain comes on after a certain time doing that thing, that is basically an endurance problem, right?
Mm-hmm.
Like you think, and it can be, that endurance problem could be made better by sometimes just gradually training endurance of the thing, or you have to reposition the body, give the body more option for movement, and then that makes it easier to do the thing longer, right? So we can come at building capacity from many angles, like repositioning the body, giving joints more freedom of motion decreases pressure. It also maybe allows you to share the load of your body differently, which then you're not having one area of the body have to take all that load. That's going to make you be able to do something longer, and it's going to make you maybe not feel your back if that's taking more load than, say, if we got your core, we got your hips, we got your inner thighs, and we teach people how to shift load, shift muscle contractions
Yeah.
away from the area it hurts. Like that becomes really useful, but that's training. Like I would want to do that anyway, even if back pain wasn't the complaint, because I want people to use more of their body in a more balanced way. Right. So a lot of times the symptom actually just makes things more obvious. It makes technique more obvious, right? The things we talk about from a standpoint of like, well, why is this good form versus this? Well, to me, there's really, that conversation doesn't come into play unless you have pain to work around, right? So if there is some type of symptom to work around, now you have something to say, all right, let me just adjust you a little bit. Does that feel better? Can you do this longer? Right. And it just becomes, okay, that's how I want you to do this from now on. The symptom actually gives you more of a guidance than trying to just tell someone to what position to be in.
Yeah. And sometimes I won't even adjust them if they are having pain. I think
Yeah.
it's I think a lot of people get nervous about potentially, not saying work through pain or just push through it, but I always use a traffic light analogy with people where like green light is kind of that minimal pain range. That's where it's like, all right, if you're experiencing a little discomfort, like don't even think twice. Just we're rocking. Like things look good.
Mm-hmm.
You're feeling it in the right places.
Yeah.
And then I think having people work into that yellow light range is really beneficial, where there might be some discomfort, but it looks good. They're still feeling it in the right areas. And then having a conversation about, symptoms actually after the exercise and in the 24 to 36 hours after, and what they can expect, and kind of what an appropriate decision-making tree looks like there, I think is really beneficial and empowering for people long-term to not really be scared of having some pain in specific exercises.
Yeah, 100%. Yeah, and I think again, it comes back to this idea of let's try to view pain as just another sensation in the body, and it's
Absolutely.
subjective, right? It's that the idea of what someone refers to as pain is very specific to them. So if the feeling of something in your back is something that is like makes you feel threatened by it, well, maybe we have to stop at that moment. But what we can also do is, can you just change something right now that makes you feel something different, right? And like it doesn't have to eliminate like what you feel in your back, but just to appreciate that this is just part of the exercise. Like that's part of what's working there. If it gets too intense, then we can change it. We could stop at this moment. We could also make a little adjustment, but regardless, we can change it. So we have more control of your symptom than you think. And I think that's a big part of it. So it becomes a shared decision-making discussion about what to do in those moments. But I think the key is just to figure out that like it is something that is changeable. The exercise itself was not the problem. It's just, some variable there that we can manipulate. That was the problem, right? It's either duration, it's either position, it's either just, it's new, right? Like a lot of times novelty becomes the most provocative thing, right? Is you just give someone something they haven't done in a while, and they might not feel it then, they might feel it afterwards. But that becomes like the thing that you realize after a while is like, there's nothing we could have done different except, like had given you somehow more experience with this movement, which is impossible, right? So like the first time you do something becomes, almost an expectation that there's going to be something that you have to deal with. And that becomes part of the process that someone starts to understand. All right. And I like to make the analogy to muscle soreness, this idea of delayed onset muscle soreness. And most people have experienced that at some point in their life. And then I like to take the idea of muscle soreness and say, is it really muscle soreness? Like, is that what's happening physiologically? Because there's really no evidence that like you're isolating muscles in your soreness after exercise. But what it is it's a pain after exercise that's not threatening because we know what it's from. All right. And as life unfolds, what you start to see is part of that process of doing something new or doing something that would cause what you would consider muscle soreness, other parts of your body start to get swept up in that pain process. And like to me, it's like we don't really have great information out there about like what we call muscle soreness, delayed onset muscle soreness, what that is specifically.
Yeah.
But what makes more sense to me is that it's actually more of an immune response because like most immune responses that we're familiar with, like a fever, it's actually, a delayed response to some stressor in your body, right? Like that's what we can kind of like broadly say our immune system does. So we are trying to purposely create stress in our body when we exercise, but stress happens even when we're not purposely trying to do it for a variety of reasons. But physical stress will happen because we've done something new, right? So that novelty is a trigger to the immune system, and that trigger or that response is often delayed, like a fever would be delayed, right? So we've all had the experience. Most of us have probably had the experience of having a fever, and what comes oftentimes with the fever is muscle aches and soreness and things like that. But that's also not isolated to the muscles. Like we often use this terminology for stuff that we understand or we think we understand, but we don't feel is unsafe because we know what it's coming from. And we often like tie muscle into it. Oh, it's just my muscles, as opposed to it being my joints or something like that. Well, it's probably not isolated to any of those things. It's just a systematic response or a systemic response in the body that is inflammation, I'm sure, is part of that. But it'll clear out just like we like have the experience of the delayed onset muscle soreness clearing out, as long as we don't keep the threat doesn't stay on high alert because we thought we broke something or because we thought we damaged something. So I think there does need to be that understanding that like you may get pain, and we're going to try not to have that be the process because our programming is going to try to do things as gradually as possible so the body is able to adapt to the stress that we're giving to it in a manner that doesn't need to give the immune response or make the immune response that great. But sometimes that happens, and we would want that to happen if we were really in like a training mode in many ways. Like we'd almost like wear it like a badge of honor. But when there is areas that have been painful in the past, they get swept up in this process, and now it becomes threatening. So we have to be able to kind of like separate that out. And again, this is where education, how you communicate with someone, it becomes so key, because there's not a right. Like I'm not saying something that I think is necessarily like 100% right, but it is something that certainly makes sense with my own body, right? Because therapists have bodies too that feel pain, and we have to like try to understand what's going on in our own bodies. And then we see a lot of cases over the years, and we try to like make it make sense. So to me, that's something that I use a lot, and it's where my current level of understanding of what's going on there is. And I see that as probably the most common problem is adding something new creates a feeling of pain afterwards. And when we're dealing with somebody who's already in pain, the area that hurts gets swept up in that. And then it becomes, all right, how do we describe that so that we can continue to move forward? So I think that's an important part of the understanding process.
Yeah, I think what kind of is tied into that is just reassurance of people that this is going to be okay and that some of these things are normal to experience, to make sure that they still feel safe moving. And if they haven't been moving, that they feel safe with movement, because especially a lot of times with people in more of a chronic scenario, there's a fear of movement associated with it. So everything is new if you haven't moved in a long time.
Yes.
And then everything feels like a threat. And you might feel some stuff after a first session, but understand that it's temporary, that in the end, it is going to be okay in most scenarios. And I think being positive with people from the outset when it's appropriate and ethical, and makes sense is like one of the first and most powerful things we can do.
Absolutely. Yeah. And I think it goes back to this idea of like figuring out an individual's overall capacity, trying not to too quickly pigeonhole it just to the area that they're complaining of discomfort. And I certainly within the physical therapy realm, and when you're working with, under insurance, you tend to have to do that, or at least you think you have to do that all the time. But you miss, basically it's like missing the forest from the trees type of thing, right? Like you're not seeing like what that person can do. You're just really, really focusing on what they can't do. And then they start to be in that situation, in that scenario too. So like you're constantly asking, like, does that hurt? Does that hurt? Instead of like figuring out like what's nowhere near hurt.
Yeah.
And like we can up that and build that and continue with that. And oftentimes that's a big part of the rehab process, right? Is that keep people in the game and just make the whole spectrum of things look like, okay, there's only like a very small amount of stuff that you can't do right now. That's what we can work on that, but appreciate all the things that don't hurt, right? And oftentimes like that plays a huge role. And then now let's double down in a way on the things that don't hurt. And then this starts to, these biomechanical relationships are actually at play here, because if the lower back, although it's pretty central, so you can't like necessarily isolate upper or lower body and work distant from the lower back, but you can usually get a sense of like what's not threatening for someone. Is it okay for you to be on a bike and kind of get a good workout while you're on a bike? So usually you can get a response there. If not the bike, then the elliptical. So finding some type of movement that somebody can do safely, and then train it like you're trying to build capacity with it. Now you start to feel things elsewhere. All right, now I'm really feeling my legs burn. So it's not my back isn't talking to me as much anymore. And that becomes, a time that's almost like a pain reliever. It's like, okay, when you're doing this workout, you're not feeling your back because we're working on your back, but because we're working your whole body. And now we are actually successful at sharing the load better in the body.
Yeah, keeping people in the game is so huge. We see a lot of people, or like get a fair amount of athletes who come in, and we always kind of have the conversation of like, okay, like you might have a knee or a hamstring thing going on right now, but we can't let that become a conditioning issue, or actually just become untrained from this. So keeping people in the game, whether they're trying to get back to sports or whether they're just looking to be in fitness to actually be healthy and age in a healthy way, then that the same principle still stands. Right. So,
and I think to wrap it up, like, well, you can see a lot of the things we're talking about will carry over to almost any injury. To make it a little bit more specific to the low back, I think there are a couple things that I'll look for, and I'm sure you're kind of in a similar boat, that tend to help, or at least they're good starting points. So if somebody is limited with their ability to get into hip extension, which looks like a hip flexor stretch, it could look like you're in half kneeling. There's a lot of different ways to assess it, but if somebody has a hard time getting into half kneeling or getting that hip extension, that's something that I want to restore. Usually that is coupled with a loss of hip rotation internally. So having the thigh roll in, which moves the foot out. So those are two things that I'll look for. If someone's not limited there, then I'm also assessing like, okay, is this person do they have a hard time maintaining their shape or their postural control when they're doing whatever it is provokes their pain, or when I would get them to try to, exercise at higher capacities. So I think there's these two broad presentations. You'll see people that are generally stiff and tight, and that creates a biomechanical relationship in the lower back in one way, and we need to get more motion in the areas that they can't move. And then there's people that would look like they move almost too well everywhere, right? Hypermobile, some of the terminology, but usually again, this is they're moving a lot from certain areas and they're not moving a lot from other areas, but the areas they are moving from, they just tend to move, which seems excessive. And that you still need to figure out where they're not moving from and getting them to move better there. But oftentimes what that looks like is more stability-based work, where you actually have to hold positions in the center so that they're not moving too much from there, so that they can start moving from other places. And it looks like strength work with a real focus on not not losing postural control, not losing position, more than how heavy do you go. And then oftentimes the weight will come, but the focus is on postural control and positional control before adding load. Often tempo plays a big role in that. But again, if the more it looks like training, the quicker it looks like training, and not isolated low back, dead bug, clamshell type exercises, the better that person's going to do.
Yep. Couldn't have said it better.
All right. Yeah, I think that about will wrap it up. I mean, hopefully there'll be some follow-up questions to this, because I know a lot of people have questions about low back stuff. And you can't, it's hard to answer anything directly via email or via comment. But what can be done is, if there is a specific question about, it hurts with what, then that can absolutely be a video, a follow-up that can be done to address that, and just at least have a discussion about some of the biomechanical relationships that could be at play if you're getting pain at a specific part of a movement, or at a certain time of day. There's definitely a more specific discussion that can go. I mean, we're talking broadly about low back pain. I think we touched on a lot of areas that are really important, but there's certainly more specific comments that can be made. So for the audience out there, if you have any specific questions, please put them in the comments. This will be on YouTube. This will also be on Apple Podcasts. I'm going to have it up on Instagram. So if you're following us on Instagram, send a comment and we'll do a follow-up video.
Awesome.
All right. I will see you next week.
See you then.